It is I received it in my thoughts. It gives a great pleasure to introduce myself.
Sir, we are on live. You can start the session, sir. Thank you. Prasad, sir, am I audible?
Hello. Now, shall we start? Because I'm not getting any sound out here from the other side. Okay, share screen. I have to go to the share screen now. Yeah, share screen. I have to share screen. I have to show my screen also, na? So in share screen, what I have to go? I have to actually copy the presentation from my desktop. Yeah, share is there. I clicked on that. What to choose? What you want to share? Entire screen, Chrome tab. It is it is giving entire screen. Then I have to upload my presentation. Okay. 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 So okay, entire screen. Okay. Uh, Actually, this entire screen, it is not taking actually the command. Actually, it only gives cancel only. It's not giving share. Yeah, yeah. You see, entire screen is there, and then the option comes is cancel, no share. Uh, yeah, you can do that. Hello, hello, hello. I will new share. Yeah, I'll share screen. You see, yeah, there is there. Yeah, I pressed it. Yeah, Okay, no. Yeah, share screen is there. Yeah, it is there. I pressed it. There is an arrow. There is, the green button. Okay. Hello. Yeah, yeah. We see it comes to choose what you want to share. So then entire screen it comes. When I press it, it doesn't take the command. Then you got to only cancel. I actually, in my desktop, I have opened my presentation. Yeah. So it is a WhatsApp, but no, you want it by mail? Shall I send you a mail? Yeah, yeah. You see, when I press the share screen, actually that option of desktop doesn't come here. Yeah, it is that it is not opening. Only that gets highlighted the entire screen. Then thereafter it comes cancel. That's all. Yeah, window and Chrome tab is there, but it's not getting highlighted. Only the entire screen is getting highlighted, but it is not accepting the command. Yeah, I've done that. Share option is not coming, only cancel is coming. Okay, okay. Actually, when I cancel it, the entire thing disappears. There's no option for actually sharing them. Yeah, yeah. Hello. There's some. Shall I send the to you? Okay, I will do that. Yeah, I will do that. Okay, I will do that. Actually, I will send it to the same mail from where I got the link. Hmm. Yeah, please do that. Okay, no issue, no issue. Okay. Yeah. It is indeed a great honor and a privilege to hear today. Hello. Hello.
So you can start the session. You can start your presentation, sir.
Hello. Am I audible? Yeah, I've seen everything, but I'm not able to hear you. No, you see, just listen. When I'm presenting, are you able to hear me? Okay, okay. I'm not actually getting, any response from your side. That's the only problem. So how I say that change the slide? How can I communicate to you? Okay, 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 okay. Now shall I start now? Good evening, my dear doctors. At the outset, I am grateful to IJCP for this med talk, and this is my first session. And I will introduce myself. I'm a senior pulmonologist who has been associated with the specialty for almost 4 decades, and I worked as a professor in King George Medical University, in AIMS Jodhpur, and Amrita Institute at Kochi. And prior to that, I was the senior most consultant pulmonologist in Indian Armed Forces. And the topic which has been chosen today is very interesting and a very appropriate topic from the perspective of a general physician as well as that of a general practitioner. Asthma is a common problem, and asthma is not only confined to our own country, but also it is a global problem. And it is estimated that about 300 million people are being affected by asthma, and then is more common in children than in adult population. And it can present in mild to very severe form, and it is a severe form of asthma, which is challenging, and that is why this topic has been chosen. Next, please. What exactly is asthma? Bronchial asthma is a heterogeneous condition which is characterized by symptoms of breathlessness, wheezing, cough, and tight chestness due to variable expiratory flow limitation. So, this is an airway obstructive disease where there is a variability in the expiratory flow. And this is basically because there's a widespread airway obstruction due to airway inflammation. So it is an airway inflammatory disease which causes widespread airway obstruction with variable expiratory flow limitation. And there is also variability in the disease presentation itself. Over time and severity, there is a wide degree of variability. And it is reversible. Of course, if it is persistent and chronic, it becomes irreversible. And there have been large number of factors which either induce or trigger this condition. And airway inflammation persists even in asymptomatic. Therefore, it is the control of airway inflammation that is key to the control of asthma. Next, next please. Airway inflammation, when you do bronchoscopy and you do a bronchial biopsy, you find that the whole airway is inflamed. It is reddish, there is denudation of the epithelium, there is secretions, there is eosinophils, there is mast cells, there is basophils, then there are dendritic cells. And the hallmark feature of airway inflammation is that all types of cells are involved, but most predominantly it is eosinophilic inflammation. And this airway inflammation leads to the release of various cytokines. And this airway inflammation, specifically in case of asthma, is a type 2 airway inflammation where there is predominant release of interleukin 4, 5, and 13. They are the ones which are related to the eosinophilic maturation, migration, and release of these various cytokines. And this eosinophilic inflammation is the one which is responsible for the mucus hypersecretion, edema, and also for the bronchospasm. So the bronchospasm, which is due to the contraction of the smooth muscles, the bronchial narrowing is because of the edema, and also because of the secretions, the mucus secretions. All these three things contribute to the airway obstruction. Next slide, please. As I told you, it is prevalent globally. 300 million people have been affected. 8 to 10% of the population suffer. We don't have the exact data, but it's a rough estimate that 8 to 10%. The children are more often affected than the adults. And the male-female ratio is 2:1. And the adult, of course, it may be equalizing, especially in case of females during the menopause, premenopausal, or during menstruation, the asthma can become worse. And an ISAC study in India shows that we have roughly about 6% of population affected with asthma in various forms, in a mild to very severe type of asthma. Next slide, please. As I told you, it's a heterogeneous condition. There's an interaction of genetic environmental factors, and various genetic studies have shown that there is involvement of chromosome 17, Q21, 5q, C17, Q21 in childhood asthma. And then it is a multifactorial disease where there is genetic, environmental, and social factors. They all contribute for this airway inflammation. And smoking, virus infection, obesity, exposure to high allergen during childhood, infections, drugs, gastroesophageal reflux, psychological factors, exercise, occupation, they all contribute to the development of airway inflammation. Infections like viruses, mycoplasma, chlamydia are notorious to produce the hyperresponsive airways, and soon after this infection, the airway inflammation persists, and this continues long, and many times those who are mildly asthmatic, they become severe following a viral infection. Even the drugs like beta blockers, cholinergics, aspirin, those, especially those who are associated with nasal polyps and aspirin, it produces what is called the Samton syndrome, and that is where even a small dose of aspirin can produce a very severe type of asthmatic reaction. And non-steroidal anti-inflammatory drugs also can result in asthma by actually skewing the metabolic pathway of the pathway of the fatty acids in the cell to either to a leukotriene pathway or cyclooxygenase pathway. It's a cyclooxygenase pathway which leads to the bronchospasm. It is the lipooxygenase pathway, actually, that is these leukotrienes, they can also lead to certain leukotrienes causes as severe bronchospasm. So it is skewing this particular metabolic pathway. where the bronchoconstrictors predominate over the bronchodilators, and there is what is called the aggravation of asthma. So that is how the drugs act to cause the triggering of asthma. Next slide, please. Now, even the food like coloring agents, cold and icy food, and the diet which is deficient in vitamin C, omega 3 fatty acids, vitamin A, selenium, zinc, and magnesium, they can affect the airway smooth muscles and then can result in bronchospasm, the triggering of the airways, the triggering of the muscles, and hyperresponsive airways can be because of the deficiency of these uh, micro elements and also vitamins. High sodium content omega 6 polysaturated fatty acids can also result in triggering of asthma. Next slide, please. Exercise, uh, 10 to 15 minutes of exercise can actually lead to the bronchospasm. 80% of asthmatics can experience exercise-induced asthma. Cold and dry air actually causes the changes in the osmolality and the pH at the local glucosal level, and then so this can lead to the release of mediators, and there is bronchospasm and airway inflammation. And 10% of asthmatics who are young, they have an occupational exposure to isocyanides, platinum, chrome, nickel, dyes, salt, cotton dust, wood dust, organic, inorganic, pharmaceutical industry. All this can lead to asthmatic airways. Next slide, please. So the risk factors for exacerbations, it is if the asthma is not properly controlled, even a small, uh, you know, trigger can make it worse. Then those who require very high doses of SABA, that is short-acting bronchodilators. So that means it is actually a rescue medication. Their inflammation is not controlled, and they are likely to have a very severe exacerbated of the asthma. And inadequate use of ICS can again lead to exacerbation of asthma. And those who have a persistently low FEV1, that is forced expiratory volume at 1 second, if it's less than 60, that means of the 60 of the predicted value, again, you may have the predisposition for the severe attack. Socioeconomic factors, persistent exposure to smoke, allergens, obesity, especially in the middle-aged females who actually have obesity, who have gastroesophageal reflux, who have sleep apnea syndrome, they are more likely to develop severe attacks of asthma. And then those who have airway inflammation, eosinophilic airway inflammation, where you do the sputum examination and you find the sputum has got eosinophils and elevated, the nitric oxide, the expiratory nitric acid, nitric oxide. So they are the one who are likely to have a very severe attack. Pregnancy, one third of the pregnant ladies, the asthma can become worse. And those who had a previous history of severe asthma, who have been intubated, they're likely to get again the recurrence of the problem. So those who had preceding one or two attacks of severe exacerbation and last 1 year, again, these are the risk factors for a severe attack. Next slide, please. So those who have a persistent exposure and who have a persistent eosinophilia, who are not adequately using the ICS, they can develop fixed airway obstruction. And these are the cases who behave like chronic bronchitis. And this obstruction is irreversible. And it can progress also. And it can lead to pulmonary hypertension, carpulmonary. So we should avoid this fixed airway obstruction. Next slide, please. So when we look at the asthma, all that wheezes is not asthma. So it can be an airway obstruction due to inhaled foreign body, an endobronchial tumor. It can be vocal cord dysfunction. It can be a COPD with an acute exacerbation. It can be an entity called the eosinophilic bronchitis, chest syndrome, bronchiectasis, gastroesophageal reflux, left ventricular failure. That's called the cardiac asthma. Pulmonary embolism. They can also present with acute severe breathlessness. and pulmonary eosinophilia, they all should be considered in the differential diagnosis of acute severe asthma. Please remember, we have to consider this as possibility because the approach to the management of these conditions are entirely different. So, for example, left ventricular failure, cardiac asthma, has to be managed differently from that of the bronchial asthma. Next slide, please. Next slide, please. So, sometimes it is difficult to differentiate between an acute exacerbation of COPD and asthma, as you know, is usually occurs in childhood. In COPD is a disease of the middle age and the later age group. There's a history of smoking and history of pollution exposure, and then there's a history of chronic winter bronchitis, and then of course it's not reversible. And then nocturnal symptoms are relatively uncommon in case of COPD, but in case of asthma, it is severe. It can occur because at night the allergen load may be high. There could be gastroesophageal reflexes, and also the level of this the drugs may be low, and also the adrenergic the drive may be low. So therefore, all those factors which actually leads to bronchodilation may be decreased at night, and that's the reason why the nocturnal symptoms in case of asthma may be higher. But in case of COPD also, nocturnal symptoms can occur because of the diaphragmatic dysfunction, pooling of the secretions, and also associated cardiac dysfunction. So it is not that nocturnal symptoms are uncommon in case of COPD. And when you give bronchodilators, in case of asthma, they show a very good response, and there is what is called the reversibility. If you do 2 puffs of salbutamol, 2 puffs salbutamol, and do the peak expiratory flow after 15 minutes, or you do a spirometry and you measure the FEV1, and you find that there's an improvement in the FEV1 of more than 12%. And also the absolute value of FeV1, there is more than 200 ml. If there is increase in the 200 ml of FeV1, or there is increase in the FeV1 by 12%, that means there is a good bronchodilator response, and it's a reversible process. And of course, airway hyperresponsiveness, the triggery airways, is a hallmark feature of asthma. In case of COPD, of course, the noxious substance can also result in what is called the hyperreactive airways, but it is not reversible in case of COPD. Next slide, please. So, in case of COPD, especially you find the diffusion may be decreased. Of course, residual volume may be increased. And in case of asthma, also residual volume may be increased because of that is dynamic hyperinflation. So the diffusing capacity is preserved in case of asthma. And of course, if you do allergic test, it will be positive in case of asthma. And sputum will be rich in eosinophils in case of asthma. In case of COPD, neutrophilia is a feature. And exhaled nitric oxide, of course, is increased in case of asthma. Next slide, please. So when today's topic is severity, when there's severe asthma, if you do FeV1, it is less than 40. And when it is life-threatening, it is less than 25% of the predicted value. Normally, FeV1 should be more than 80% of the predicted value. Here, you find that in severe asthmatics, the FeV1 value will be less than 40%. And life-threatening is less than 25% of less than 25 of the predicted value. Next slide, please. Next slide, please. What exactly is acute severe asthma? It was earlier called the status asthmaticus. They will have serious symptoms. What are the symptoms of asthma? They will have breathlessness, wheezing, cough. Okay, these are the hallmark features. And they will have severe symptoms. And they are in a respiratory distress. And the respiratory rate is more than 25. Their pulsus paradoxus. That means there's an inspirative fall in this blood pressure. Will be more than 10. And in case of severe asthma, it is more than 25. And also the pulse rate is high. They have tachycardia. And Pulsus paradoxus occurs when the peak expiratory flow is less than 60% of the predicted value. And severe cases, what we call the silent chest can occur, and that is the V's may be absent. That means if the entire passage is, there is no airflow at all, is the patient is totally exhausted, number one, not able to take a breath. And then there is also the plugging of the airways. In such cases, you can have a silent chest. When those cases who have died of, the severe asthma, in postmortem they find that the entire airways, small airways and the large ways are all plugged with mucus, with the mucus. So there's hardly any flow. There is no ventilation, hyperventilation. So the silent chest is due to severe bronchospasm and also plugging of the airways. And hardly any air moves in and moves out. There is no ventilation at all. And the life-threatening features of asthma, if they have cyanosis, they have silent chest, they have bradycardia, they have hypertension, and the peak expiratory flow is, 25 or less than 30%. And the ABG shows, normally when you hyperventilate, there is a respiratory alkalosis. There's a washing out of the carbon dioxide. But when there is hyperventilation, when the muscles also get into respiratory muscles go into a fatigue, you find that the CO2 level, which is normally between 35 to 45, it starts climbing up. We call it the crossover value when the PCO2 becomes 40. And thereafter, they can develop what is called the hypercarbia. Hypercarbia. And different degrees of hypercarbia can occur, and they go into carbon dioxide narcosis and unconsciousness. And that indicates the patient has got a very severe life-threatening asthma. The complications of this hyperventilation is dehydration, and when there's hyperventilation, and also increased airway pressure during expiration, and there is a dynamic hyperinflation, when there's an increase in the autoplete, that is during expiration, then there is a chances of rupture of the airways, the lung, the small blephs and bulla, and they can develop interstitial emphysema, or they can develop pneumothorax. They can develop pneumomediastinum, they can develop pneumothorax, and that can be life-threatening in these cases. And of course, there could be acute carpulmonary, acute right ventricular failure that can also occur in case of acute, severe, life-threatening asthma. Next slide, please. So we have several groups of asthmatics who are difficult asthmatics. There are 5% of asthmatics are very difficult to control with a conventional therapy. It may be because of poor compliance, exposure to high allergens, infections, G reflex, rhinosinusitis, use of certain drugs, all these things, or they may be resistant to steroids. So all these cases are very difficult to treat asthma. And there's another group called the brittle asthma. That means the patient may be absolutely fine in the morning, and in a matter of few hours, there's a sudden dip in the peak expiratory flow. There's a wide variation in the peak expiratory flow, and they can go into a very severe, unpredictable attack, and it can be life-threatening, and it can lead to catastrophe and death also. So these are the difficult asthmatics. And we have to identify these type of groups, and we have to control these cases to prevent the acute attacks, which can be life-threatening or which can lead to the death of the person. Next slide, please. So, in chronic asthmatitis, we have Global Initiative for Asthma. GINA guidelines are there. So we have a stepwise approach. So if you have a mild or occasional symptoms, you use short-acting beta-2 agonists. Then, to control the airway inflammation, you give low doses of ICS or leukotriene receptor antagonists. And those are step 3, you have low dose ICS and long-acting beta-2 agonists. And then, of course, you can also try immunotherapy, sublingual immunotherapy. And then step 4, we have medium dose of ICS, LABA, and you can also give, sustained release theophylline, a low dose, which can also control the airway inflammation, which can also stimulate the respiratory muscles, and it can be used In addition, you can also use leukotriene receptor antagonists. But in those who have a severe, persistent, allergic, uncontrolled asthma, and these are the cases where the eosinophil level is very high and who have the IG levels are high, in such cases, we use anti-IG molecules like omalizumab or anti-IL-5 molecules like resulizumab, mepolizumab, or IL-5 receptor, benralizumab, receptor antagonist, benralizumab, or IL-13 antagonists like dupilumab can be used. Of course, they also require steroids. Oral inhaled steroids are required in these cases. Next slide, please. Next slide, please. Next slide, please. So we have various groups of drugs which are used for a treatment of asthma. But before that, in cases of status asthmaticus, so what is important is that all these cases has to be assessed properly. You have to differentiate between the other differential diagnostics which I told you, like acute exacerbation COPD, or whether they have airway obstruction or the eosinophilic inflammation, chest or syndrome, left ventricular failure. So that means these patients should undergo the CBC, absolute eosinophil count, sputum for eosinophils. If they're able to this one, you may have to do ABs in these cases. Then, of course, you have to do ECG, you have to do echo. So these are all mandatory requirements. But in emergency situation, you may not have much time, and a bedside X-ray you may do. And most important is that you have to start the treatment as early as possible after having, come to a conclusion that the patient has got acute severe attack of asthma. And we have various groups of drugs like bronchodilators, which are beta 2 agonists. We have anticholinergics, and we have theophylline. Then we have controller drugs, which actually controls inflammation. We have the inhaled corticosteroids, systemic steroids, leukotriene modifiers like montelukast, zephyr etc. Then sodium chromoglycate, which is specially used in case of children. Then, as I told you, anti-IG therapy is there, anti-IL-5, anti-IL-13 therapy in cases who have got a chronic persistent severe asthma. In such cases, we can use them. Then you can do antigen-specific immunotherapy when you have a ragweed or you have certain pollens or certain insects, house dust mite or cockroaches. In such cases, you can also try antigen-specific immunotherapy. It is a slow process. You have to have patience, and they can also develop severe anaphylaxis. And in some cases, of course, chronic persistent asthma, you can also do thermoplasty. Alternative treatments like yoga, hypnosis, acupuncture, they also can play a role in the control of these cases. And the drug delivery, we have the mid-dose inhaler, which can be used in acute situation. Then you have nebulizers, which of course are used in acute situation, the treatment of acute severe asthma. Next slide, please. So I don't want to go into details of short-acting beta 2 agonists, but in case of acute severe attack, you can use 2 to 6 puffs of these short-acting beta 2 agonists as a salbutamol, leosalbutamol, to spacers. You can give, and you can repeat it every 20 minutes for 1 hour. Or you give nebulization with 2.5 milligram of salbutamol. And every 20 minutes you repeat it. And so for severe attacks, 2.5 to 5 milligram every 20 minutes. So you can also give albuterols, 10 to 15 milligram administered continuously. You can also continuously administer it. Leosalbutamol puffs, as I told you, can be in 4 to 8 puffs, or it can be nebulized every 20 minutes. In some refractory cases, you can also use epinephrine, 0.3 to 0.5 ml, 1:1000 dilution subcutaneously. And you can repeat it 20 minutes. Or you can use tolbuterol, 0.25 milligrams subcutaneously. And you can repeat it after 20 minutes. So, of course, today we don't have the CFC, chlorofluorocarbons are not there because they have freon, which reduces the ozone layer. As per the Montreal Protocol, After 2006, it has been banned, and today we have a HFA, hydrofluoroalkane, as a propellant, and that is used in all these MDI, metered dose inhalers. Next slide, please. So, LABA in moderate to severe persistent asthma, we use ICS, inhaled corticosteroids. Also, we use long-acting beta agonists like salmeterol or formoterol. And formoterol also has an intermediate action compared to salmeterol. It's a long-acting one. We have an ultra-long-acting one also, vilanterol, indicatorol. These are the ultra-acting, beta-2 agonists. And their benefit substantial compared to leukotrienes, theophylline, or increased dose of steroids. So they benefit. So LABA has become an important component of the treatment of moderate to severe persistent asthma. Next slide, please. ICS can be administered even in acute situation by nebulization. You have the Budicard nebulization, 1 milligram, or you can nebulize with the budesonide, 1 milligram, and it can be nebulized frequently, every 4 to 6 hours. And then you can also use it in combination with the long-acting beta-2 agonist. So various combinations available. The budesonide, beclomethasone, they're all available. Mometasone, they're all available. They can be used in combination with salmeterol or formoterol, indicatorol, vilanterol, etc. And they have been used. Then if you give high doses of ICS, that means more than 1,000 micrograms daily, it can cause systemic absorption, and also it can also affect the pituitary, adrenal axis also, and therefore, and it may affect the growth in case of children. And as far as possible, we have to keep the lowest minimal dose to control the airway inflammation. Next slide, please. So, in an acute situation, the systemic steroid should be given. The methylprednisolone, 125 milligrams, should be given intravenously, initially, or you can give hydrocortisone, 200 milligrams. In an acute severe left-lung asthma, you give 200 milligrams of hydrocortisone as an initial treatment. Of course, once the patient is able to tolerate the oral drugs, then you start the patient on oral prednisolone at a dose of 1 milligram per kg body weight. And you can give a short course of steroid for 7 to 14 days in these cases. Next slide, please. So, I have already told you, we have wide varieties of drugs. The second line treatment, we have the leukotriene receptor antagonists, and we have montelukast, zephylucast, xeluton, etc. Then it can be used specially in case of aspirin sensitivity, exercise-induced asthma, those of allergic rhinitis. These are the cases where these the leukotriene receptor antagonists play an important role in the control of this asthma. Omalizumab is specifically used when you have a chronic, persistent, severe asthma, which requires steroids, who have got eosinophilia, who have got very IgE level. When the IgE level is between 30 to 700, so in such cases, omalizumab can be used in a bi-monthly dose. We have different doses available, 150 milligrams, 375 milligrams. It can be given subcutaneously twice a month based on the IgE level, and you give it for, say, 4 months. And one of the problem with this is that you can develop severe anaphylaxis. Next slide, please. So, in case of asthmatics, severe asthma, you also use what is called the short-acting muscarinic agents like the can be used, or you can use a long-acting, the muscarinic agent like tiotropium. So can be used. So you can use a short-acting beta-2, sorry, the muscarinic agent can be used, and 0.5 milligram of the short-acting muscarinic agent can be given in a nebulized form, or you can use a combination of ipratropium bromide with the salbutamol, which is available as a Duvalin or so. Ipratropium bromide is a short-acting muscarinic agent, which can be used as a nebulizing agent, or it can be also used as an inhaler. So you can give the 3 to 4 puffs in a spacer when there's an acute situation or acute severe attack of asthma, or you can nebulize this patient with zero point 0.5 milligram of ipratropium bromide nebulization solution, and it can be repeated uh, every 20 minutes during an acute attack, and for 1 hour, and thereafter you can repeat it every 6 hours. Then, uh, in severe cases, some desperate situation, you can also start the patient on IV derifylin. You can put 450 milligram of IV derifylin in a saline, and then you can do a slow infusion, continuous infusion, over the period of 8 to 12 hours. And IV magnesium sulfate, those who have refractory to the standard therapy, after 1 hour of nebulization, as per the protocol which I told you, then give 2 grams of IV magnesium over 20 minutes. It can be used in acute, severe, uncontrolled asthma. Inhale haloxmister, that is oxygen and helium at a ratio of 70 to 30, can also be given uh, in case of very severe asthmatics, and it is actually it reduces the airway turbulence and it increases the airflow. So antibiotics are indicated when there is a secondary infection. When there's a secondary infection, in such cases, we can use antibiotics. And so bronchial thermoplasty, all these things are used when you have chronic persistent asthma, and that is not the scope of today's talk. Next slide, please. Next slide, please. And in addition to that, 100% oxygen should be given those who have a very severe asthma, who comes with acute severe asthma or who have a status asthmaticus, they should receive 100% oxygen. And our aim is to keep an saturation between 90 to 95%. And those who have associated pregnancy or cardiac problem, this is a must. Mechanical ventilation is only indicated when the patient has got bradypnea. There's, there's hyperventilation. The patient is going to unconsciousness. There's serious cyanosis. The CO2 is going up. So in such cases, you have to try mechanical ventilation as a last resort. And you have to mechanically ventilate with a big endotracheal tube. And the endotracheal tube size should be more than 75, 7.5. And you should give low tidal volume. And you have to increase the prolonged expiration. The IU ratio, the expiration should be prolonged to prevent the dynamic hyperinflation and autopy. And then you have to increase the inspirative flow. The rate should be low, inspirative flow should be high. And then you have to have a low peak to prevent dynamic hyperinflation. And they will not be able to tolerate such a type of the mechanical ventilation interventions. So heavy sedation is required, but avoid paralytical agents. So that is when the patient has got acute, severe, life-threatening asthma, where the mechanical ventilation has to be instituted as early as possible. Next slide, please. Next slide, please. So we have various side effects with this medication. SABA can produce tremors, anxiety, tachycardia, and then it can also cause prolonged QT. Mild lactic acidosis can occur. ICS, as I told you, if you use more than 1,000 micrograms consistently, especially in case of children, you can have skin bruising. They can have the features of the, the Cushing's. They can have cataracts. They have elevated intraocular pressure, accelerated loss of bone mass can occur, and pharyngeal, laryngeal candidias can occur, and so they have to rinse and you have to use spacer to minimize the laryngeal pharyngeal candidiasis. And leukotriene antagonists are especially useful. Can I mean can lead to chest syndrome, vasculitis, but these are anecdotal case reports. And then, of course, it can steroid tapering may be difficult in these cases. Gelatin can result in hepatitis. And if you use short-acting beta-2 agonists, then in fact it can lead to asthma mortality. It can lead to asthma mortality. So whenever you use beta-2 agonists, you also use the steroids. That's very important. Short-acting beta-2 agonists, when you use them, uh, it can only cause a rescue medication. It does not control the asthma. And that is the reason why the mortality, sudden mortality, which was reported in Australia and New Zealand, was attributed to the high use of the short-acting beta-2 agonists. And when you use methylxanthine, it is a narrow therapeutic indices, and so the drug level has to be between 5 to 10. If you use higher, then that can lead to various side effects, and including the arrhythmias. And if you use the low dose, of course, it will not control the asthma. So somehow the Indian population, they can tolerate a dose of 5 to 10 microgram of uh, drug levels of the methylxanthines. Next slide, please. Next slide, please. So this is just a repetition of what I've already told you. The medical treatment of acute severe asthma, beta-2 agonists, you use salbutamol, metoprolol, aripiprazole, epinephrine. They can all be used, and nebulization 2.5 milligram, normal saline via nebulizer, or 4 puffs to 8 puffs. That is, 4 puffs contain 400 microgram. It can be given through the spacer. It can be repeated every 20 minutes for 3 consecutive times. And then, of course, and those who are not responded, you can try magnesium sulfate. And epinephrine can also be used when they have not responded to nebulization. And epinephrine 0.3 ml, 1 is to 1000 solution subcutaneous. It can be repeated every 20 minutes for 3 doses. And steroids should be started. 15 to 240 milligram daily in divided doses can be given. Methylprednisolone can be given 60 to 125 milligram IV every 6 to 8 hours. And in severe asthma, you 100% oxygen. And titrate to keep the SpO to more than 90%. And in severe attacks, when you give such a high flow oxygen, and when the ABG, if it shows the CO2 is going down, in such cases, of course, you try NIV, non-invasive ventilation, and if it fails, in such cases, you may have to intubate these patients. You have to intubate these patients. And anticholinergic drugs in acute situation, ipratropium bromide is used 0.5 milligram via nebulizer every hour into 3 doses to be given. To be given 3 doses. Next slide, please. So, treatment, save the life, give oxygen, nebulize, use steroids. In desperate situation, I'll give IV aminophylline 250 milligram over 20 minutes, magnesium sulfate 2 gram IV slowly. If no response, exclude complications like infections, pneumothorax, pulmonary embolism, etc. And monitor these cases every 15 minutes, pulse oximetry. Peak expiratory flow may not be possible in these cases because they are too breathless. And if the saturation less than 30%, 90% do NIV. If the NIV fails, and if the respiration is unstable, go for mechanical ventilation, intubate with a large size endotracheal tube, and use you have to give low tidal volume, increase the rate, and increase the expiratory time. And in these cases, you have to do heavy sedation. Next slide, please. Next slide, please. So, a word about antibiotics. It is similar to the acute exacerbation COPD. So, whenever you have a tracheobronchitis, acute exacerbation chronic bronchitis, so the most likely organisms are influenza, mycoplasma, streptococcus pneumonia. So, drug of choice in these cases is amoxicillin, tetracycline, Ceptron, and alternatively it can include cephalosporin, second generation macrolides, amoxicillin, clavulanic acid, fluoroquinolones, and those who have a suppurative airway disease, who have a chronic persistent asthma, and who also associated suppurative airway disease, and you may have a pseudomonas infection, and they may have a multi-resistant gram-negative organisms, and in those cases, you have to do anti-pseudomonal fluoroquinolones like ciprofloxacin, or you give parenteral therapy with piperacillin, tazobactam, etc., meropenem. So these are the drugs which can be used when you have suspected pseudomonas infection. Next slide, please. So one word about autopep. Because they are hyperventilating, there's hardly any time for the expiration to take place, and there is a severe bronchospasm and there's the obstruction. There's a severe expiratory flow limitation, and therefore there's air trapping, and this is called the dynamic hyperinflation. And this dynamic hyperinflation keeps the lung in a hyperinflated state, and therefore the inspiration is not able to achieve the maximum, the tidal volume, which is required for the ventilation. So, and there is hardly any ventilation in these cases, and autopep therefore has to be reduced. And autopep can be reduced if you relieve the bronchospasm, and also you have a controlled ventilation. If you do a controlled ventilation by increasing the expiration, and also if you do a proper nebulization, reduce the bronchospasm, then in such cases, autopep can be reduced. Next slide, please. Next slide, please. How do you measure the autopep? The autopep, previous slide, please. Previous slide. How do you reduce the, how do you measure the autopep? The expiratory port is when you open it, at the end of expiration, when there is no flow, at the expiratory port, the barometric pressure, the manometric pressure is equivalent to the alveolar pressure. And in case of severe obstructive obstruction due to asthma, what happens when you do, when you actually they open the expiratory flow, the port, in such cases, there is no airflow at all because of bronchospasm, and there is the autopep generated is 15, 20, or maybe much higher, and this can lead to ballooning of the airways, and it can lead to pneumothorax. Okay, and when there is a relief of bronchospasm, and then when you actually open the, and when you close the expiratory port and then connect to a manometer, in such cases you can actually measure the PEEP, and that auto PEEP can be measured. That means when there is when the airway pressure in the airway is reflected at the mouth end, then you can actually measure the autopep generated. And this autopep is the most important factor which can lead to the ventilatory failure. Next slide, please. So it's just a repetition of what I've told about the ventilatory strategies. You give initially either a volume cycle or a pressure cycle, pressure support ventilation, and then you keep a low PEEP, and then tidal wall should be low, is 4 ml per kg body weight. The plateau pressure should be less than 30 centimeters. I ratio should be 1:3. Inspiratory time should be 1 or 1.5 seconds. The rate should be minimum to minimize the autopsy. And this is what the ventilating strategy that we adopt in case of severe exacerbation of COPD or asthma. Next slide, please. So, after having treated these cases, what is important is that we have to maintain the asthma control. And asthma control means we have to optimize the treatment and ensure that the patient becomes asymptomatic. And asthma control is supposed to be good when there is no need to use SABA frequently. Or you use SABA, short-acting beta agonist, maybe once or twice per week. And the daytime symptoms are not there. And the even symptoms are there, they're mild, maybe they are once or twice per week. Night symptoms are not there. And when it is well controlled, there is no symptoms at all. When it's partially controlled, that means they have daytime symptoms and also they have the nighttime symptoms. And uncontrolled means they have persistent daytime and night symptoms. Next slide, please. So, ladies and gentlemen, I have tried to give you a broader perspective on the management of asthma. I try to go into the specific details of acute severe asthma, which is a life-threatening situation and which can mimic other life-threatening situations like vocal cord palsy, can be airway obstruction due to a foreign body, or eosinophilic uh, bronchitis, chest syndrome or vasculitis, or pulmonary embolism, left ventricular failure, so pneumothorax. So these have to be kept as a differential diagnosis, and more importantly, COPD with acute exacerbation. So after having ruled out all these possibilities, and once you have made a diagnosis of acute severe asthma, that means they have a very severe attack, pulsus paradoxus, even they may have unconsciousness, the CO2 retention, they can go into unconsciousness. So they are very severe cases and they require urgent emergent measures. And the most important measure is nebulization with a short-acting beta-2 agonist and also with the muscarinic agent like ipratropium bromide. You give it for 1 hour, and if they don't respond, you magnesium sulfate. You can also use subcutaneous adrenaline, or you can use terbinafine subcutaneously. You use high doses of steroids. Methylprednisolone, you can give 60 to 125 milligram intravenous. You can give repeated every 4 to 6 hours. And those who respond, and if they are able to take oral, you can also start simultaneously the oral steroids, 1 to 2 milligram per kg body weight. You give methylprednisolone, and you continue the steroid for 5 to 7 days, and thereafter you taper the dose of the steroids. And those who have not responded to the initial treatment, in addition to what I told you, with oxygenation, NIV, and these beta 2 agonists, steroids, in such cases, and who have a very severe attack and who have a respiratory instability, and the CO2 is going up, they have a respiratory acidosis, their respiratory muscle fatigue. So these are the cases who have to be mechanically ventilated. Mechanical ventilation can be associated with high mortality, and the autopip has to be controlled in these cases. And autopip can be controlled by actually reducing the respiratory rate, reducing the tidal volume, and optimizing the bronchodilator therapy. So I have given you uh, a specific perspective about the management of acute severe attack of asthma. I have finished my presentation, and if you have any queries on these specific issues, I shall be delighted to actually answer them Sorry that my lecture started a little late, but even then, I tried to condense my talk within that 15 minutes or so. So, another 10 minutes you can devote for any questions. I should be delighted to answer them. Thank you so much. Yes. Yeah. 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 Okay. So the question is, what are the cellular components, elements, are the airways of the lung, which dysfunction lead to bronchial asthma? I will tell you that we have different types of cells in the airway. The lining cells are the epithelial cells. Then we have lymphocytes. We have T lymphocytes. We have helper T lymphocytes. We have T4 cells and T8 cells. Then we have dendritic cells. Then you have mast cells. There are lymphoid cells, basophils. In us, all these cells are involved. Remember, in different proportions, including neutrophils. So we have different phenotypes of asthma. In different phenotypes of asthma, you may find involvement of all these cells. But what I could understand from your question is that the airway inflammation, which is the hallmark feature of asthma, is eosinophilic in nature. And eosinophilic asthma is the one which is responsible for this hyperreactive airways, is responsible for the bronchospasm, and it's also responsible for the bronchial edema. And this type of inflammation is called the type 2 airway inflammation. We have a type 1 airway inflammation and a type 2 airway inflammation. Type 1 airway inflammation is one where there is helper T cells type 1 are involved and they produce gamma interferon and hyperresponsive airways, what is called the hypersensitive airways. Hypersensitivity, that's a hallmark feature of the type 1 airway inflammation. Those who have been exposed to the microbial environment in the childhood, it can skew the pathway to the type 1 airway inflammation. And those who have a minimum exposure to microbial inflammation and who have been exposed to these allergens, etc., it through the pathway to the type 2 airway inflammation. And this type 2 airway inflammation is the hallmark feature of the asthma. And the type 2 airway inflammation can be triggered by epithelial inflammation, epithelial damage. Please remember, although it is a non-eosinophilic inflammation, when there is exposure to smoking, when there is exposure to pollutants, or when there's a viral infection, even this type 1, the epithelial cells also are involved. They produce a cytokine called alarmins, which can actually induce lymphocytes and which can also cause eosinophilic infiltration. So ultimately, eosinophils plays an important role in both type 2 inflammation and type 1 airway inflammation. And therefore, today, in the control of severe persistent asthma, IL-5 drugs are being used increasingly. They have been used. IL-13, IL-4 drugs. And when there is a acute reaction, when what is called anaphylactic reaction, IG response, where there is degranulation of the mast cells because of the antigen antibodies, IgE as well as antigen, when they actually deposit on the histamine producing mast cells, then we have a severe bronchoconstriction and anaphylactic type of reaction. And these are the cases where they respond to your ipratropium. So these are the cases where they respond to terbutaline and the epinephrine. And these are the cases where you may have to give anti-IgE monoclonal antibodies like omalizumab, those who have chronic persistent asthma. So therefore, we measure the IG levels, and those who have the IG level between, say, 30 to 700, in these cases, we give omalizumab. And those who have eosinophilia, peripheral eosinophilia, or they have a sputum eosinophilia, and when the value is more than 150. So, in such cases, we give IL-5 antagonists. IL-5 antagonists, as I told you, are mepolizumab, resilizumab, and benralizumab. Benralizumab is the one which is a receptor, IL-5 receptor antagonist. And the IL-5 plays an important role in eosinophilic maturation, recruitment, and the genesis or the production of eosinophils at the bone marrow. So they play an important role, the migration, maturation, and release of various chemotactic factors, eosinophilic chemotactic factors, major and the minor, and which causes the oxidant injury, which causes severe inflammation, which causes the bronchospasm, which causes the edema, which causes the hypersecretion. So the eosinophilic inflammation is the most important cellular element which leads to bronchial asthma. In case of COPD, it's a neutrophilic inflammation. But we have a phenotypes of asthmatics who have a neutrophilic inflammation. Those who have middle-aged obese females, who have sleep apnea syndrome, who have GERD, and who get infection, respiratory infection with bacteria, etc. So they can have a neutrophilic inflammation. This is also a phenotype of asthma. Asthma, as I told you, initially we thought it is all allergic, it is only eosinophilia, but today we have a neutrophilic asthma, we have non-type 2 inflammatory asthmas, aspirin-induced asthmas, middle-aged, obese or asthmatics, we have eosinophilic inflammation, IgE, dominant asthmatics like eczema, atopic dermatitis, aspirin, sensitive asthma, where you may not have eosinophilia. They have nasal polyposis. Even a small dose of non-steroidal anti-inflammatory drugs or aspirin can lead to very severe attack of asthma. And in some cases, you may have extensive mucus plugging, and they may not be having much of inflammation also. That has been found in cases of severe asthmatics who have what is called the status asthmatics. But the entire airways are plugged with what we call the mucus, and there may not be much of airway inflammation. That also, that type of asthmatics have been observed. So, asthma is a very heterogeneous condition. And our understanding of asthma, especially the cellular mechanism, became obvious because we started doing more number of bronchoscopies and we started taking the biopsies from this area. And that has really revolutionized the management of asthma. So, next question. Which age groups are most affected by exercise-induced bronchoconstriction? I think exercise-induced bronchoconstriction, it is, as I told you, it is the children, young age group, and also those who are obese and who are middle-age group. There also can develop exercise-induced bronchoconstriction, most commonly in adolescent age group. And exercise-induced bronchoconstriction, as I told you, is due to hyperventilation and local dehydration, changes osmolarity, which can lead to the bronchoconstriction, and it can be prevented by using 2 puffs of short-acting beta-2 agonist, or by using tourmaline, or you can use these leukotriene antagonists. So that is how you can prevent bronchoconstriction due to exercise. Which control agents and relief medications used in the management of asthma? How are they used? It's the same repetition as I told you. The control agents are the one which try to control the airway inflammation and which prevents the triggering of asthma with all those triggers. And the control agents, when we use, then what is important is that we say it is well controlled when you use this minimum dose of these controlling agents. When you use the minimum dose of this controlling agent, that means say the asthma control is good. When you use control agents in the high doses, and that they are not controlled, that means these are poorly controlled asthma. They fall into GINA category 4 and 5. And these are the cases where you may have to go in for the alternative treatment. What are the control agents that we use? Yeah, the long-acting beta-2 agonists. Long-acting beta-2 agonists also have an anti-inflammatory role in addition to the bronchodilatory effect. And this long-acting beta-2 agonists, as I told you, are salmeterol, formoterol, ultra-long-acting beta-2 agonists are vilanterol, indicatorol, and so these agents are used in combination with steroids, long-acting steroids or short-acting steroids. So there we have budesonide, mometasone, beclomethasone. They can be used as an inhaler or the inhaled therapy. They're all used as controlling asthma. Other controlling agents, as I told you, you can use uh, theophylline. You can also use uh, this formalin, uh, and you can also use the leukotriene antagonists. They're also controlling agents. The relief medications or the rescue medications are the one short-acting beta-2 agonists, which I already told you, salbutamol, terbutaline. These are all short-acting beta-2 agonists. You have levosalbutamol. Then short-acting muscarinic agents like ipratropium. They are the relief medication. How they have to be used? They can be used as a nebulization or to DPI. You can use as mid-dose inhalers. In long-term management, of course, you can also use dry powder inhaler. And this rescue medication should be used on SOS basis. But basically, control agent has to be used in cases those who have moderate to severe asthma. And their frequency has to be decided as per the control of asthma and also the measurement of peak expiratory flow. The peak expiratory flow should be maintained as much as normal as possible. It should be 80% of the predicted. FE1 should be also kept around 80% of the predicted value. And when the FE1 value is less than 60, and these are the cases, the ICS, inhaled corticosteroids, may have to be used to control the bronchial asthma. So, how does exposure to respiratory virus in infancy relate to the incidence of reactive asthma? Please understand that repeated respiratory virus infection can screw the pathway to type 2 inflammation, and also it can also cause the denudation of the epithelium. And all this can actually lead to the change of the inflammatory pathway to eosinophilic pathway. And the airways can become very twitchy, it can become hyper-responsive, and it can alter the immune pathways to eosinophilic inflammation. And all these things can lead to a severe childhood asthma. And even maternal exposure to this type of infections, maternal exposure to the certain drugs, and during if the maternal asthmatitis, genetic predisposition, and all these things can, the nutrition, they can also add to the severity of the asthma. Those who are deficient in vitamin C, zinc, magnesium can trigger the asthma. And the sodium metabolism, anything associated with sodium metabolism can also lead to asthma. Those who have a predisposition of cystic fibrosis, they have more chance of developing asthma. And those who are alpha-1 antitrypsin deficiency, they're also more likely to have airway obstruction. So repeated childhood viral infection can lead to asthma. And then repeated exposure to high doses of allergens can lead to childhood asthma. And genetic factors, mother having asthma, and also mother exposed to certain drugs can also lead to very severe childhood asthma. And poor development of the airways also can lead to the severe asthma. So there are multiple factors we have to take into consideration while addressing childhood asthma. So these are the certain questions that have been asked in chat box. So I had 4 questions. What are the cellular elements? I tried to address them. Which age groups mostly affected by exercise-induced asthma? I tried to address that. Which control agents, relief medication? I tried to address them. How does exposure to respiratory virus can lead to a high incidence and severity of cardiovascular asthma? I tried to address them. I think there are no more questions. So I devoted about 10 minutes on answering your questions. I hope my presentation has been useful. And if you have any other specific questions, and if the organizers permit me, I shall be able to answer them in the next 5 or 10 minutes. Otherwise, I have finished my presentation. Yes, madam. Okay. Okay. Well, I hope I have answered all the questions and my presentation has been okay. Okay. Thank you so much. I think next time when you have